The NICE guidelines recommend the use of CST as a non-pharmacological treatment for people with mild, moderate dementia. CST incorporates interventions that are previously very well researched as well, such as reality orientation, reminiscence, and multisensory approaches to implicit learning. And this implicit learning is key throughout all of the principles of cognitive stimulation therapy, and I'll touch on them more as I go through my presentation. So when delivered within the context of good person-centered care, research indicates that CST offers an evidence-based treatment for people with dementia. Next slide, please. So we were aware from research such as the IDS-Tilde study of the importance of social inclusion and participation for people aging with an intellectual disability. And of course, building and strengthening relationships is one of the key principles of CST. So we wanted to run a group because we wanted to offer people opportunities for social connectedness and social participation. Next slide, please, June. So as Gunnar pointed out, in the general population, it's recommended maybe 5 to 6 or up to 8 members in some cases. And I have found that really that's too many for groups of people who have intellectual disability. In general, I had about 4 people in the groups that I ran, but I would suggest absolutely no more than 6. But that's, I suppose, open to what you feel is right for the group, and with 2 facilitators. And the recommended time for general population is sessions of 45 minutes. So I would consider allowing additional time, at least for some of the sessions, because the creative activities certainly take a little bit more time. You don't want people to be rushed. And also, I think, you know, going back again to that social connectedness, I feel it's nice to allow people a little bit of time to chat and connect over a cup of tea. Next slide, please. So an assessment of each person's supports, needs and characteristics is really important when setting up the group. And here I feel it's really useful to link with the person's support staff and multidisciplinary team. And of course, to link with family members as well, because family members have such rich information, which is really helpful in developing person-centered activities. So what you might consider is the person's preferences and interests. So what music do they like? What are their hobbies? Their family, their life story, their strengths, which is really important because we want to really build and capitalize on their strengths, and their culture. And then their physical needs, so any health issues the person may have. Is there FEDS guidelines, for example? That's feeding, eating, drinking and swallowing guidelines. You may check with the person's speech and language therapist. Any allergies or sensitivities, any mobility issues, personal care requirements, any sensory issues, and then other issues such as their cognitive functioning, their level of literacy and numeracy, the person's ability to want to remain in the group for 45 minutes, and if there's any responsive behaviours. Next slide, please, June. So, as Gunnar outlined, it's really a very cost-effective treatment and intervention. No special equipment is required to facilitate a CST group. The manual lists a few items such as a flip chart and pens or a whiteboard, a songbook, a softball, because there's games suggested in the manual in each session, and a CD player and CDs. Now, just one of the adaptations that I made for the group of people that I was working with, instead of writing orientation material up on the flip chart, I actually provided large, easy read materials for orientation. So the name of the group, the day of the week, where we were, all of that. And I found that very useful, and I provided each person with a copy of that, which was I felt beneficial for the group I was working with. I also used an iPad. It's not necessary, but if you have access to one, I think it is useful. I used it for music clips and also for video clips for reminiscing. I just found that it was quite useful. And then any other items that are listed in the manual for activities, they're open to improvisation, and you'll actually have many of the materials, or you can access them pretty easily. And in the resource section at the end, I've just mentioned a few websites that people might find helpful. Next slide, please. So members' brains should be stimulated, but so should their sense of humour. So we really need to ensure that it's a fun and enjoyable learning atmosphere with people's friends, avoiding anything that looks like a school-like kind of atmosphere. Nothing we do as facilitators should treat members as children. And as I said earlier, learning is implicit within the group. So participants aren't really overly aware of the learning aspect, but really just perceive it as an enjoyable activity. I've included a picture there of some adult kind of appropriate activities that are easy to do. So it's possible, if you have a budget as time goes on, to purchase small pieces of equipment. Next slide, please. So orientation is an important principle of CST. Now, this is always done in a subtle, implicit way at the beginning of each session. So the information is written on a display board that you can refer to during your discussion, or in my case, I adapted that to using EasyRead. So at the beginning, you may say something in your introduction like, do you think the weather is nice for April? Or, oh, I'm glad it's Friday. So you're implicitly putting the information there. A person is never put on the spot by asking direct questions like, what is the day or what is the date? And then in the manual as well, many of the seasonal activities also provide scope for orientation. So you may be doing, recently I did something on Easter, so there's that natural orientation as well. Next slide, please. It's important to observe individuals who may appear isolated within the group. So make sure that the person has their glasses or hearing aid if that's appropriate, or if somebody's a little bit shyer, maybe encourage a more socially active group member to engage with them, or maybe have your co-facilitator support them a little bit. It's important to encourage an atmosphere where diversity of views and everyone's contribution is valued. And I kind of really like this quote, diversity is having a seat at the table. Inclusion is having a voice, and belonging is having that voice be heard. And I really think that fits very nicely with the principles of CST. Next slide, please, June. So, of course, the first aim of CST is mental stimulation to get people's minds active and engaged. And research indicates that mental activity can lead to new learning and increased cognitive functioning. So as I said earlier, when considering the person's getting a knowledge and doing an assessment of the person's abilities, consider the person's cognitive ability. Pitch the activity so that the person is mentally stimulated, but that it's not too difficult, potentially making that person feel de-skilled. And CST groups will never expose a person's difficulties. So I like to think of this as the Goldilocks rule, not too much, not too little, just right. Next slide, please, June. So if we focus on facts too much, there's a chance that people will often be wrong. But if we ask people for their opinions, they cannot be wrong. So, for example, instead of asking, where did you go to on holidays when you were a child, which is a memory question, we might ask, what's your favourite place to go on holidays? And we might give a range of photographs to back this up. So we would also always avoid asking questions beginning, who can remember? Because that is just quite taxing. Now, next slide, please, June. So the aim of CST is to continually encourage new thoughts and ideas and associations rather than just recall previously learned information. And one example is to present a range of pictures to participants and ask them what they think about them. So in this scenario, I've just provided 2 pieces of art. It could be more. So you ask people their opinions on the different types of art, the colours that they think might go together, ask them what they see or what might be going on in the picture. Do they prefer traditional art or modern art? And then participants can also be supported to categorise the pieces of art, so into colour, black and white, or into classic modern. So there's lots of scope within activities to explore. Next slide, please, June. So reminiscence is an excellent way of tapping into a strength that many people with dementia have in terms of recalling experiences from much earlier in life. Sensitivity is needed not to push members into exposing painful memories in the group setting. But again, the more you know about the person from doing your assessment and exploring knowledge of that person, the less likely that this is to happen. And reminiscence is also a really useful tool towards orientation, which is a key principle of CST. And many of the sessions in the manual will allow you to compare old and new, thinking about how things have changed over time. And, you know, last year we were running a group. There was one gentleman in the group, and we were exploring old television programs. And we were talking about the Reardons, which was a soap back in, I think it finished in 1979, about a farming family in Ireland. And with one gentleman, this really resonated with them. It was amazing how he could talk about the characters, he could name them, and he could even give detail on some of the episodes that happened. So for somebody who wasn't maybe as communicative as the other members, he really shone with this. But then we were able to kind of use it as an aid to the here and now. We talked about, well, how has farming changed over the years? What was different then? What do you think is better now? And we got into the most fantastic conversation, including organic farming. So it's just an example of how reminiscence can be used to aid to the here and now. Next slide, please, June. So multisensory cues are really important in your CST group. Memory works much better if you do not rely on just one sense. So for example, identifying sounds in the sound session is helped by providing pictures or objects as well to help people identify the sound. And in the food session, it's greatly enhanced if people can see, taste, smell and feel the food. Because words in a discussion may soon be lost when memory is limited. So having a range of sensory items really helps to keep members' attention and focus on the activity. Next slide, please, June. So there's evidence from the research that language skills improve with CST. So many of the sessions stimulate language, for example, naming, categorization, word association, and proverbs. Next slide, please. So the group program is not prescriptive. For each session, there's a suggested choice of 2 levels of activity A and B, and that's in the manual. And level B activities are less demanding on the person's memory and other cognitive skills. So you can choose the level that seems most appropriate to your group. You can mix from the 2 levels, or you can come up with your own ideas. And when you're working with people in the ID population, even level B can be quite difficult for some people. So you might have to adapt that right back to your own ideas. But the manual is useful in giving you an overall format and actually gives you ideas that you can adapt to suit the group that you're working with. Next slide, please, Jim. So that brings us up to the present time. So we were doing the face-to-face CST sessions, but of course in 2020, due to COVID-19 restrictions, it wasn't possible for us to continue face-to-face sessions. We were really conscious that people were missing out on social connections, and people were telling us that. And this was kind of borne out as well. The IDS-TIL report on the impact of COVID-19 on people aging with an intellectual disability in Ireland 2020 indicated that 45% of people reported that they were missing seeing their friends, and this was our experience as well. So in 2021, Roscommon Chatters moved to an online programme. Now, our main objective for this group was really to provide people with opportunities to maintain social connections with their friends, and it wasn't from a CST point of view. So it's not a pure CST programme. However, I have included one aspect of CST in it. Next slide, please, June. So this is just to give a brief outline of what the virtual session looks like. So we're kind of using a similar framework. We start the group with welcome, theme song, and an orientation discussion. I also send out resource packs before the session to tie in with what we're going to be discussing and doing. And then for the main activity, we have actually PPAL's physical movement. This is quite interesting. PPALS stands for People with Intellectual Disability as Physical Activity Leaders. And we were lucky enough to be part of this programme, which was rolled out by Trinity College Dublin and Age and Opportunity last year. And 13 people that we support who have intellectual disability trained as physical activity leaders. So on different sessions, one of our PPAL leaders actually leads out that session, which is very, very nice. It's just a short exercise session and people really enjoy it. So then I include one of the CST activities here. They're not all suitable at all to adapt to an online, so we're limited in that, but people really enjoy what we do. And then we have some music and a member's contribution where the member can, say a poem or sing a song, or maybe just say what they've been doing during the week. And then finally, we finish that off with just a couple of minutes of mindfulness or relaxation, talk about the next session and the content, and say our goodbyes. Next slide, please. And just to give you a flavour of, this is just some feedback from the members that had participated in the group. So we asked them, the key of it may be covered there, but we asked them 3 questions on the different activities. Did they like the activity a lot, shown in blue? Did they like the activity a little, shown in orange? And then there was a light purple for they disliked it. Now, people were really kind. Nobody said that they disliked anything. But it's just interesting, I think, to share, because as you can see, seeing friends was really very important for people. That's what they enjoyed very much. And then the activity was the other thing that was really popular, and this is a CST activity. So it just illustrates that people really, really enjoyed that part of it. Next slide, please, June. It's just resources that I've put there that I have found helpful, that may be useful to people. So, to summarise, I suppose our local experience in Roscommon has shown that CST appears to be beneficial for adults with intellectual disability. But as Gunnar spoke to earlier, the research on that is extremely limited, and more is warranted for this population. Now, thank you very much for listening.
Much, Pauline. That was very interesting presentation indeed, and very practical way of showing us what you do, and really interested to see even the how participants felt about it, and seeing friends, as we found during COVID, was just so critical to people, and it was just a lovely way to see them involved. I'm glad to see them using the PPALS program, so I'm really pleased about that. So that's wonderful. So thank you, Pauline, for that. Okay, I have a number of questions, and again, a number of questions have come in through the Q&A, and I will try to get through them as well. And if you have particular questions, please do put them in through there. I'm going to start with Dr. Jeanette Turl, And Jeanette, based on your experience, do you think that non-pharmacological therapies can complement the use of medications for dementia for people with an intellectual disability?
Thank you, Mary. I think it's vital, actually. I think that you're really trying to, apart from using your acetylcholine esterases to improve cognition, what we're really trying to do is to avoid the use of medication wherever possible. Medication really should be one of the things that we think of, I suppose, as the illness progresses, as a last resort type of therapy. Apart from trying to use the acetylcholine esterases, perhaps in Alzheimer's disease and mild to moderate dementia, we're really trying to use cognitive stimulation to improve people's, to make sure that people's memory stays intact, to make sure that they don't get bored, that they keep their joie de vivre, that they keep in all those little bits that make us human, all those little bits that connect us with other people, all those bits that enhance our own sense of validity in the world. And I think that certainly the NICE guidelines in England would certainly recommend them as one of the first line therapies for mild to moderate dementia, as well as perhaps looking, as I say, as the acetylcholine esterases. So there's two aspects. One, your cognition. If you're trying to maintain your cognition and your emotional well-being, then perhaps you don't go on later on to get the behavioral and psychiatric manifestations of dementia. Because once we go on to that stage, then we're really trying to avoid medication wherever possible. That's in the new national clinical guidelines on looking after people with dementia. Medication is something that we use, but we're really trying to make sure that our memory, that we use the neuroplasticity that's in our memory, and try and stimulate all those neurons in the best way we can. And I love the fact that it's very, gentle, and it's enhancing the normal works, and that you're trying to use that Goldilocks model that Pauline talked about. You're trying to, make sure that people's normal capacity. Certainly in the CARA unit where I've worked, and Gunnar has worked there too, what we found is when people were having the cognitive stimulation sessions, we had much less BPRS, that's the behavioral and psychiatric manifestations of dementia. It really enhanced people. The more work people have, the more we use these kind of stimulations, the less we see loneliness, the less we see that sense of what I am to be a human, that sense of mastery of my environment. The more we see those things being used, the less we see the other things. That's been my clinical experience of it.
Okay, great. Yeah, because that related to another question, which I think you have answered in terms of how they can play a role in reducing responsive behaviours that we often see. And I think you have answered that. But is there, I know you mentioned, Jeanette, the NICE guidelines. Is there other medical guidelines and recommendations around the use of these therapies in dementia?
I suppose that we will be looking at our guidelines also here in Ireland, and we have new national clinical guidelines. I think it's number 21, just looking at my sheet there to be sure. And that's easily available on gov.ie, and looking at appropriate prescribing for non-cognitive symptoms in a person with dementia. I think they would have a role there. I think that they've a role in cognitive symptoms, but I think they've also a role in the non-cognitive symptoms too. They are a first line treatment in terms of preventing other secondary behavioural and psychiatric manifestations. I think they should be used. So whilst we might have the NICE guidelines to guide us on those non-cognitive symptoms, I think they are just one of the things that we should be using. And I think there's more and more research looking, as we are desperately looking for cures for Alzheimer's disease and vascular dementia and preventative strategies. I think this is also a preventative strategy. If we can get those neural connections working, if we know that having social cohesiveness helps us meeting people, and the research that you've done in the Tilda on living with, working with COVID in a time of COVID, we know that our clients have been one of the most, I suppose they've been the most segregated of everybody. And we've all seen for ourselves the clinical sequelae of that, the loneliness, the lack of contact, the isolation, the lack of day activities. And I think that we've all seen that has really had an impact on cognitive and non-cognitive symptoms.
Yeah.
There is certainly much more research. There's a recent paper in the British Journal of Advances in Psychiatry on looking at behavioural therapies for BPRS, which isn't exactly what cognitive stimulation is doing, but I think it will prevent those BPRS symptoms. So I think that's where it's vital.
Yeah, great, and thank you very much, Dr. Terrell, for that. And certainly the data that we showed from IDS Tilda when we did the first COVID report, and Pauline showed that data, really talked about the high level of loneliness, the high levels of stress and anxiety. And we will be repeating that COVID survey now. We'll go back out to services in Ireland in May and repeating. We did that during May to September of last year during the first lockdown. And given the length of the lockdown and the prolonged isolation that people with intellectual disability had, I can imagine that many of those things are much worse for people similar to the rest of us who have found this extended lockdown extremely challenging and very different. And it's really heartening, Pauline, to see how you have brought it online to combat and how successful that has been. So that's really interesting and really important that it can be used in that way. So thank you for that. Gunnar, I have a question, and this is in relation to, obviously CST was developed for the general population, and we've heard about the fact that there is limited research, and the way we need to bespoke it in a very person-centered way to make it meaningful for people with an intellectual disability. If the way CST has been developed in the general population has been really looking at people with mild dementia. So for people with an intellectual disability, regardless of dementia, what's your experience in using it with people with moderate to severe levels of learning disability? Or have you used it with that population?
No, we haven't used it to date, but I think that's something for the future to consider for researchers and people who run CST of what to do with the people with more advanced dementia. I think will be an important aspect of the future for CST,
Yeah.
I think there's one, I think there's a PhD student in University College London who's currently looking into a CST group for moderate to severe dementia. Yeah. It'll be very interesting to see what she comes up with.
Yeah, I think so. Yeah, I think so. And I think the big issue, and I know I'll ask Pauline to respond to that question as well, is about, obviously really trying to have the group that are compatible in terms of level of dementia and learns of disabilities, so that the activities are meaningful for everybody. Pauline, do you want to talk a little bit on how you've managed that?
Yes, and I suppose the guidelines are, the group members should ideally be at similar stages of dementia so that activities can be pitched accordingly. It's really recommended not to have too wide a range of ability in the group, because some members may become very frustrated and it becomes very less person-centered. So I suppose there's a range of things as well that you need to consider when putting the group together. So, potentially can the members be able to engage in small group conversation? And, are they likely to wish to remain in the group? So I think it's very important, going back to kind of that assessment of people, that when you're setting up the group, that you group it according, to the person's needs. And I would suggest running maybe 2 groups if resources allowed, rather than putting people together that aren't compatible and it's not going to be beneficial.
Yeah, okay. Marianne, do you want to respond to that or share your experience?
Yeah, I suppose just going back to what Dr. Jeanette was saying as well around the importance of that social connectedness piece. I've just noticed from some clinical referrals coming in that people are in danger, I think now at this stage, of being labelled as having mental health issues or challenging behaviour issues, when in fact what's happening is a very normal response to a very abnormal situation, and we're all in for the last year. So I suppose it's very important, as all of us in terms of supporting people, particularly ageing with ID, that we look at social connectedness and try and promote that through the use of CST or something like Roscommon Chatters, in all of our services, so that people are not at risk of these kind of responses, very normal responses to being very lonely and isolated in their homes. That's something I just wanted to highlight from today.
Yeah, absolutely. One of the question coming in here from the participants is, are pre to post assessments used to gauge the impact of the program? So Pauline or Gunnar, you might want to respond to that.
Well, I think the CAM-COG is used a lot to assess the cognitive ability. And then there's various measures of quality of life that are used as well. So those are usually the two main ones for the ID population.
Yeah, it's the CAM-COG and quality of life measures. It might be useful perhaps to put into the chat box, you know, some of the, you know, what measures people are particularly using. I think, and sometimes we're trying to measure maybe the wrong thing. And really what we're looking at, I often feel is a sense of enjoyment, a sense of connectedness, a sense of quality of life, an absence of responsive behaviors. I mean, and they're probably the things we should be looking at. I'm not sure, Pauline, if you want to say anything on that.
Yes, I would absolutely agree with that. Like Gunnar, we would use lots of instruments like the CAM-COG and the DLG, you know, to measure cognitive decline. But I agree totally, Mary, with what you're saying. And sometimes it's the informal kind of assessment of, well, is the person enjoying this? What's their response? So staff are even able to kind of gather some of that informal information as well. And I think absolutely, if it's adding to somebody's quality of life, but yes, we would use some quality of life measures to do that more formally as well.
Yeah. Okay. And another comment coming in, great ideas, and although it says that no training is needed to run a course, it appears that it looks highly skilled. I think really, from my experience, being able to facilitate these groups does require skill and understanding exactly some of the things that Gunnar and Pauline, I suppose, talked about, how you actually facilitate a group, how you actually bring in people. And like if we're to bring in this widespread into ID services, one of the risks will be that perhaps people are not used to facilitating groups, and it could be a stressful situation for participants. So certainly I do think that there is a level of training both to be a facilitator and a co-facilitator that people really, I think we would be recommending that people should undertake. Yeah, Gunnar, you might want to give your opinion on that.
Well, yeah, I guess for people with extensive training in how to run a group may not need particular training for CST, but somebody who may not be used to run groups at all, it might be useful to attend a training course. And I think they usually just a day-long undated training.
Yeah, but just a day-long training, yeah.
So it's probably good to do for people who have no experience running groups at all. Yeah.
In the case of people with Down syndrome, would this therapy be useful for people as people age often before any diagnosis? So perhaps Jeanette, I might get you to respond to that. Yeah.
Well, that's an excellent question. And I think the difficulty is we all work in services in which we've got quite a lot of people with Down syndrome who are approaching that age of concern. And it's often very difficult to know, isn't it, who is approaching that particular age. And you might have people that you're questioning. Certainly the cognitive stimulation, they're brilliant for everybody. And, you know, in some of our services, we do have little areas in which we have people that we might have a group of people that are naturally clustered together into let's say, having 6 or 7 people with Down syndrome at a particular age of concern. But to buy into what Pauline and Gunnar have said, it's to make sure that your groups are matched so that you have people of equal ability. Because not only are people with Down syndrome not all the same, they're not a homogeneous group. There are people with severe degrees of intellectual disability, people with moderate, that might be in a day centre. And then we've got people that are attending training centres. So we have to make sure that whatever group we're doing, we have equal levels of ability. And then we have the dementia piece on top. But certainly having those some gentle memory work is no harm for everybody. And it is an excellent, I suppose that's an area we have to look at, isn't it?
Yes, it is, absolutely. And that's why we have a lot of focus in the memory clinic on brain health. And because really, I think that is the most important issue for people who are aging with Down syndrome. And I know, Marianne, I want you to come in on this, because really keeping people's brain mentally active, keeping people cognitively stimulated, for all of us is just so important. But we have to make a real effort. I often say that many people with Down syndrome are doing nice things and they have a nice quality of life, but they're often not doing things, engaging in lifelong learning, or doing things that taxes the brain and that challenges the brain. And I think this is really important now as we see this population age. Marianne, you might want to speak to that.
Yeah, absolutely. I think there's a need, and I can see from the questions coming in that a lot of people watching the masterclass are aware of this, for a more structured approach to brain health and supporting people to get out of their comfort zone. And we know that people with Down syndrome can age prematurely. I would always say, support a person, a young person with Down syndrome, to reach those life goals as early as possible, so they have a good quality of life and they challenge themselves for as long as possible. And look at the cognitive stimulation, look at the social connectedness, lifelong learning, physical activity, all of those things that we know are so important for people to have a good long life and living well with Down syndrome.
Yeah, excellent, great. Another question here is, will the Glasgow Depression Scale be a useful scale? Jeanette, you might want to respond to that.
I suppose the Glasgow Depression Scale has a particular, it has a particular aim in mind. So looking at depression, and I think that the behavioural and psychiatric, the BPS, it's not just depression, it's other things. It's anxiety, it's perhaps sometimes psychosis is the biggest, or this kind of quasi kind of, is it psychosis or is it not, is a very difficult one for us to measure. So it's good, but I think we have to probably look at what's reasonable and what we can actually do in time, as in, we might be doing the CAMCOGs in any event, but we mightn't want to overburden people by doing too many screening tests. So it would depend on what we're looking at. Are we looking at depression for somebody? I think it's much more complex than that. I think there's so many different things. There's so many neurotransmitters that we're losing. We're losing them all at different times and in different places. The first one that we know we lose is the acetylcholine, and that's where the cognitive symptoms come in. And then later on, we've got our serotonin, our dopamine, our glutamate, our noradrenaline. So they're all over the place, and it's very difficult to know which one is responsible for different things. And I suppose what I would want to say is, medication at the end of the day, it's not a magic bullet. We are trying to avoid it where possible, apart from the acetylcholine esterases, which are very specific for cognitive symptoms. And I think there's a lovely phrase that was used recently in the media for something Mary said there. I think we're languishing. I think that's the word for people. We're all languishing at the moment, for want of a better word. And like the flowers in the spring, we need a good watering or a good bit of sunshine to improve our mood. And that goes for we're all doing much better. And that's the thing I think of each day when I come into work. I'm lucky. I'm in my office. I can move around. My clients don't have that privilege that I do, to go into work and to find a new environment and to have myself stimulated every day. And I think that's what we would love to provide for them, that sense of social connectedness. I get in, I move, I go from one place to the other, and that sense of I meet people. As we open up, that we'll be able to do much more with our clients. But it's great to see the Zoom like we're doing today, being used for the clients, because I think that's great, and many of my clients are finding it very easy to use it as well.
Yeah, I think if the COVID pandemic has done nothing else, it has brought technology into the lives of people with an intellectual disability, and that is to be truly welcomed. I really want to thank everyone. There is a number of questions coming in around training. Yes, I think Gunnar put up on his last slide, which we will be sending to people, where people can access the one-day training course. I've done it myself. I think it's excellent. I would encourage people to do it. And one thing that I would say is we need a much stronger evidence base, and that's the unfortunate issue for us within the ID sector. Often we just don't have a good evidence base, but hopefully we are certainly looking to roll out this at the Daughters of Charity Disability Support Service, and to really set up a study there to look at the utility of this. And I'd like the opportunity, perhaps, if people are interested, to talk to people about that as well. I just want to thank, we're over time. I really want to thank all of our speakers.